Okay, good evening, good morning, good afternoon, everyone, wherever you are in the world. Welcome to another GLODAM webinar. So this month, this is our topic for the month. It's clinical cases and histological insights in the diagnosis of hair disorders in Africa. And our speakers are Dr. Helmut and Dr. Hashim. So you can see the topic as I've discussed, and we'll go a little bit more into who our speakers are in another slide, but just a few housekeeping slides. First of all, we are members of the GLODAM Trainee Committee, and our hosts for today are myself, Dr. Karen Waithera, and Dr. Pauline Ogola. So we are both dermatology residents, and we are members of the GLODAM Trainee Committee, which is a part of the International Alliance for Global Health Dermatology, also known as GLODAM, under the IFD. Our mission is to promote knowledge equity by enhancing access to dermatology education worldwide. And we have three main key initiatives. The first one is educational webinars, where we provide free high-quality learning opportunities. We also provide networking and collaboration through connecting trainees worldwide, and a podcast series where we address challenges in global health dermatology. So as part of our meeting etiquette, your audio will be muted throughout the webinar and your camera will be turned off. Also, please submit any questions you may have through the chat or the Q&A function, where Dr. Pauline will also be sharing some other key facts about GLODAM and also about the topic today. Our meeting host will share this with other speakers to answer at the end of the webinar. We'll also be sharing further information about the GLODAM Trainee Committee in the chat function. So some more information about our speakers. So they're talking about the clinical cases and histological insights in the diagnosis of hair disorders in Africa. And our speakers are Dr. Helmut, who is the head of dermatology in dermatopathology at the EOC, where he's responsible for dermatopathology at the EOC in Bellinzona and Locarno in Switzerland. So since 2009, he has been leading a project to develop dermatopathology in sub-Saharan Africa. And he says that being a mentor gives him the chance to share what he has received with others. And for both mentor and mentee, it is an opportunity to grow and to see new horizons. His values are respect, responsibility, and inclusivity. He's a committed clinician, a curious dermatopathologist, an enthusiastic teacher, serving his community and collaborating on projects aimed at improving skin health where this is needed. Dr. Hashim is a consultant dermatologist and venereologist and the section head at Aga Khan University Hospital in Nairobi, Kenya. He finished his MMed at the Regional Dermatology Training Center in Tanzania in 2019, and he became a consultant dermatovenerologist, widely working in Kenya. And originally, he worked in a private hospital, and he has since shifted to a university hospital since May 2022. He hoped that this change will better the patient care that he offered in the city of Nairobi. And in his spare time, Dr. Hashim enjoys card making and origami. So he says that his love of art aligns closely with the love for dermatosurgery, which he carries out as part of his current role. So thank you, and it's on to our speakers.
Excellent. Hello, everyone. How are you? Welcome to this series of the GLODAM webinar. Can everyone hear me?
Yes.
Yes.
Right, super. So today I have the pleasure of presenting with my mentor, Professor Helmut, and we'll be presenting on the clinical cases and histological insights in the diagnosis of hair disorders in Africa. Next. So we have a series of cases. This is the first case. This is a 28-year-old female who noticed 2 months of hair loss over the vertex of her scalp, presenting with a bit of itching and sensitivity, and she says that has been there for the last 6 months. There is minimal hair loss, but the hair has been progressively getting worse in terms of the patch which she's getting. Clinically, we have a hair loss just over the vertex. Next. Next. Okay, this one. So when you look at this particular slide, this is the demoscopy of actually what we are seeing in terms of clinical features. So we see very specific features which help in the diagnosis, and we use a dermatoscope to actually get us this particular visualization. So when you look at this patient's scalp, you notice that there's very classical peripilar cast that we're seeing around the hair follicles. They're very specific for central centrifugal cicatricial alopecia. Um, it's peripheral edema, which is there, we see. We see also changes in the pigment network. And very importantly, we see also a little bit of hair shaft dysfunction. So you'll see there's some areas of hair which are a little bit larger and some areas which they're actually getting thinner and thinner. So these peripilar white-gray halos are actually the pathognomic feature of CCC-A, as we're going to come to look at it in a bit. And they're very specific to this kind of hair loss. Next. So what is the diagnosis? I mentioned it a bit earlier. This is grade 2 central centrifugal cicatricial alopecia. Next. Next, we have a case of a 40-year-old female. She has a 15-year-old history of loss from the frontal hairline, but she has also progressive loss of hair over the vertex of the last 10 years. She presented with initial itching. The scalp was quite sensitive and initially was diagnosed as multiple areas of fungal infection, was given some antifungal shampoos, but nothing was really helping. So currently she's presented with some mild associated itching with a bit of sensitivity, especially just where the hair loss has been persistent. She's been having braided hairstyles over the last 5 years, and she also has history of relaxant and chemical use in the past. Next. So when we look at now a clinical picture for her, you see that there is a very specific hair loss, which we see right in the center of the scalp, which is associated with a bit of patchy distribution. It's very symmetrical. And when you look at the frontal part of the hair, you'll actually notice that it's similar, but it's a very aggressive form of a hair loss that she's actually been having over the last 10 years. Next. So when you look at now endoscopically this slide, you'll see that this shows the actual condition of what's going on the scalp. We have a bit of peripilar peripilar graying and whitening, like the way I mentioned in the previous picture. However, with the aggression of the hair that we've seen now in this particular case, you notice that there's also other specific findings that we're seeing. So we have the yellow arrow showing yellow dots to white dots. They're more of empty follicles. And also we see that there is a bit more change in the pigmentation comparatively to the previous slide that we see. There's less pigmentary dysfunction. There's more halos around it. And also what we see is that there is a lot of perifollicular scaling. So when you look at the blue arrows on the right side, this side, we'll see that there is more scaling that we're seeing other than just the normal hair which we saw in the previous slide. Now here also you'll notice that there's much more hair loss comparatively. Next. So this is a little bit further into the scalp, and we see that actually now the hair follicles have reduced. There are more areas of empty space. There's more areas where there's no hair in the follicles, and you'll actually notice that there's pockets of hair. Next. So again, we have another diagnosis of central centrifugal cicatricial alopecia, but now this is grade 4. So when you look at the previous slide, we'll have an earlier stage of central centrifugal cicatricial alopecia, but now as we've seen in this case, the aggression, the hair loss is more, then the grading is more. Next. Our last case in this series, now that we know the previous 2 slides, so I'm sure you're already guessing, again, a patient with hair loss over the last 25 years, but this is a 52-year-old female, so much older. She has very minimal itching or sensitivity on the scalp. So there's hardly any symptoms she's presenting. She's just presenting with hair loss. She's complained of having multiple consultations in the past, has used minoxidil, some hair serums, but with no improvement at all. Next. Now here you see completely different in terms of what you're seeing demoscopically. You see that there are a lot of empty follicular ostia. You see that there is a variance in the hair distribution. There is a loss of the pigmentary, or what we call the pigment network. And the most important is that we're actually seeing now empty ostia. So where the hair follicles should have been, we're seeing no hair. Next. So this is the case of now grade 5 central centrifugal cicatricial alopecia. And next, coming to what are the clinical pearls, this is what we need to see in terms of history and in terms of what we are looking at in terms of observation in trichoscopy. So most of the times patients present with a hair loss, which is mostly around the vertex. Then there is associated symptoms like pruritus, pain, sensitivity, but there's also sometimes complaints of flaking, which is then more often misdiagnosed as fungal infection. In terms of visualization, we're seeing that peripilar gray-white halos, which is the pathognomic feature in trichoscopy of CCCA, but we're also seeing a bit of follicular scaling, which sometimes looks like a bit like a cast, but it's not exactly a cast. There is loss of follicular ostia. There is pinpoint white dots, which is like an empty space, reduced honeycomb pigmentation, and there's hair shaft variability. Okay, next. Now I come to the second case series, where now we have a 35-year-old female with hair loss over the frontal part of the scalp since 10 years. Also noticed that she's losing eyebrows, was seen by multiple doctors, and hence resorted to seeing a trichologist as a last option. The trichologist opted to do a hair transplant after doing some platelet-rich plasma, but she still did not notice any hair growth. So she was now in a desperate situation because there was increased burning sensation, there was itching, sensitivity, and hence the reason for the consultation. Next. So when you look at this particular patient, you notice that there is a massive amount of hair loss from the frontal area all the way to the marginal area, all the way going to the back of the head, associated with patchy hair distribution. On the right picture, we see that there's actually a bit of some sort of hair that has started growing back, but it's still very patchy, and it's in a very patterned distribution. This is where the hair transplant was done. Next. So when you look at now with polarized light, you can actually notice that there's very classical loss of eyebrows, but you also notice there's a little bit of facial pigmentation which the patient is presenting with. When you look at the scalp, there's pinpoint areas of inflammation, which you can actually see with just a normal lens. Next. So when you look at now the classical symptoms of this particular type of hair loss, this is where we have frontal fibrosing alopecia as a diagnosis, but we have specific findings that we are seeing in terms of dermoscopy. The most important one is the pathognomic feature, which is peripilar hair cast, which is the white area which we're seeing specifically around the hair follicle. We also notice that there's a massive amount of hair loss compared to the other slides. There's empty follicles or empty ostia that we're seeing. There is a little bit of scaling, but you notice that the hair loss is quite massive compared to the previous slides. Next. Here, this is a little bit towards the side of where the hair transplant was done. And you can see that actually there's no features of hair transplant remaining. There's actually just very, very specific hair cast remaining. Changes again in the pigment network. But most important, where the yellow arrow is, you can actually see white dots. This is very specific for actually now where there's more amount of hair loss, which has now become aggressive and has now become more of scarring. Next. So again, the diagnosis here, as we've seen in the clinical situation, would be frontal fibrosing alopecia, but with a little bit of features of facial pigmentation. Okay, next. So we have now another 60-year-old female coming with progressive hair loss. Again, same from the frontal areas, but she's mostly now complaining of facial pigmentation. So you see, this is slightly a bit more different because she's actually noticed the pigmentation. She's a bit older, so initially she was thinking that the facial pigmentation was just due to menopause, but as it's increasing, that's when now she decided to come for the consultation. The hair loss which she has presented was she thought was normal for her age, which is very common in our African ladies to see hairline receding. So she thought this was just natural. Her eyebrows, she's lost quite some time back, and she uses cosmetic camouflage to actually cover them up. Next. So when you look at this particular situation compared to the previous slide, you notice that there's very specific cutoff of the hairline. This is you see a very classical hair band-like hair loss, which is just like, you can see it's like a band-like circulating or circumambulating around the entire scalp. So she's lost hair not only in the frontal area, but over the entire scalp in a ring-like fashion. But you also notice that she has very pinpoint gray to black dots on the face and patches on the neck as well. Next. On the neck, they're actually much more prominent, especially when you look at the presentation. They look very confluent, but sometimes it's often mistaken as erythema rather than pigmentation, but they're usually grayish to red, sometimes pigmentations, mostly gray in our setting. Next. So when you look at now her dermoscopical findings, you see there's hardly any hair remaining. What we call a lonely hair sign is very classically seen in one particular corner. But when you see this, most of the osteas are actually empty. And you actually see this particular yellow dot sign, which is basically where a very classical situation seen in our African, so which is often mistaken as empty follicles, but is not follicles which are there. Next. Now, the frontal scalp, when you change a little bit of contrast and you see in more of a polarizer, you can actually appreciate much more scarring comparatively, but you can also see the pigmentary change that is occurring, especially right in the center. Next. So this is the facial dermoscopy, and we'll actually see that there is increased pigmentation that we actually very well appreciate on dermoscopy rather than actually the clinical presentation. So you see the classical gray, white, gray, brown dots that are usually seen in dermoscopically over the face. Next. So again, the diagnosis here, which one we've seen with clinical, we arrived at something called frontofibrosing alopecia. But because she's had extensive pigmentation, we also added lichen planus pigmentosus to the diagnosis as well. Next. So what are the clinical classical findings and trichoscopic classical findings that we see? So the hair loss is very progressive. It's band-like, and it's alopecia, which is not only frontal, but it actually involves the entire hairline. The hairline also, alopecia also sometimes extends to the eyebrows. It's associated with scalp pruritus, scalp sensitivity, and sometimes a burning sensation or a bit of I would say discomfort. In terms of visualization, we have the classical peripylar cast that we've seen now in some of these, the initial case. But we have seen the classical reduced loss of follicular ostia seen because generally when you look at this particular type of alopecia, it gets scarred. So a lot of times the follicular ostia are what we generally see as the plain white dots. The yellow dots are follicular hyperkeratosis and keratotic plaquing. And there sometimes we see the perifollicular scaling, but it's more appreciated in central centrifugal cicatricial alopecia. Next. Now coming to the third case series, we have a 25-year-old female with, 25-year-old with receding hairline for approximately 5 years. There's no other symptoms she's complaining of. She's got hair plating done since she was the age of 13, but she very classically mentions that every time she gets her hair down, she needs to take some painkillers to ease the headaches, which persist for at least 1 to 2 days. Next. So when you see this picture, you see classical hairstyles, which are often seen in many of the ladies in Africa. And you'll notice that there is very specific amount of pulling, which goes on in the central part of the forehead. And you see that there is a massive amount of hair that's taken and pulled to the back. This is what we call braiding. Next slide. Now, when you look at polarized light pictures, which is mild magnification, you notice that there's a lot of tension that you see right on the hair follicles. This is what we call tenting. But when you look at dermoscopically, there is a very specific or very classical finding called a flambeau sign, which is seen as someone's shining a flashlight in that direction. So particularly when you look at this whitish pigmentation, it's usually seen in the direction of hair cast. Second classical findings is actually the hair casts that are seen because of the amount of pulling. You're going to see very specific casts that are seen around that area. Next. So what is the diagnosis here? We see mild marginal traction alopecia. Next. So here we have a 28-year-old female with receding hairline again, but this time more time, almost 10 years. The plating has been done for quite some time. And again, she's been taking some painkillers like our previous patient every time the hair plating has been done. She has history of also chemical uses in the past. Next. So here again, we see same amount of pulling, but you'll actually see that there's a bit of a different hairstyle here, which is called extensions, where you add in different amounts of hair to the natural hair to increase in terms of beautification. Now, here, classically, we see what we call a fringe sign. It's where there is loss of hair in the frontal area and is replaced with very thin, fine hairs. So when you look at it in terms of dermoscopically, that's when we actually see what these fine hairs are. But here again, the blue arrow shows the tinting, and you can actually see sometimes the casts in actually just normal magnification. Next. Next. All right, super. So here now, when we no, so when you look at the dermoscopy of this particular patient, the classical villus hairs we see usually in this particular diagnosis are very easy to view. We have empty follicles, but again, the same similar casts that we see in the previous patient because of the extensive pulling. So these are the hair casts that are usually seen. But again, the flambeau sign, which is the arrow in yellow. Next. So again, what is the diagnosis? I mean, it's very easy to say, but this is more moderate marginal traction alopecia. Next slide. Now here we have a 37-year-old female, but hair loss since the last 10 years, having no associated symptoms, has used minoxidil in the past, but has stopped due to financial constraints. Currently has come due to see what we can do to assist with the hairline. Next. So when you see there's a massive change compared to when you see the previous pictures compared to this one, you see there's much more hair loss, and it's almost reaching the line of where the ears are. Next. So when you look at the dermoscopically of this picture, you see it's quite different as well. There's very minimal casting that we're seeing there, very minimal flambeau sign that we're seeing. Instead, we're seeing empty follicles. We're also seeing a little bit of scarred ostia right here on the top. And also when you notice the hairs, there's very minimal villus hairs that we used to see in the previous two slides. Number two, there's hair shaft dysfunction, meaning that when you look at the hair in terms of the thickness, there's quite a change in the thickness and variability. Next. So what is the diagnosis? We have severe marginal traction alopecia in this particular case. Next. So in terms of history and trichoscopy, in terms of what are the classical signs, what you need to look out for, history of tight braids, extensions, these are very classical signs preceding alopecia, which is the traction alopecia. There's progressive hair loss, and sometimes patients may present with traction alopecia, so I have not seen any cases recently. In terms of the trichoscopy, you see fringe sign, or which is the villus hairs that we see in that particular area, which is mostly affected. Then we have the cylindrical casts, which are seen just encircling the proximal hair shaft, which is called the flambeau sign. We have yellow dots, empty follicular openings as we progress to more scarring alopecias and sometimes scarred ostia. Next. So here we have a case of a male patient, this time, a 20-year-old. Just say they had noticed hair loss overnight, no associated pain or anything like that. Next. So you see classical symmetrical hair loss in patchy-form alopecia, which is seen just around the occiput in this patient. He only complained of these two patches. He didn't have any other patches elsewhere. Next. So here we actually see a very specific form comparatively now to trichoscopy compared to the other slides, where you're seeing very specific empty follicles, or what we call the yellow dots. All right. These are the ones which are specifically associated with traction alopecia. Alopecia areata. And when you look at these particular areas, you notice that there is also broken hairs. There is a little bit of villus hairs. And in some areas, next. Sorry, actually, I don't think I have a slide. There is a bit of areas where there is a bit of exclamation there. So here, when you look at this particular diagnosis, you're looking at alopecia areata. Next. So here, similar case, male patient, again saying that sudden hair loss has been seen, has not used any medications and no associated symptoms. Next. So you see a very progressive hair loss pattern, but in comparison to the previous case, this is where now we see a very specific exclamation mark or exclamation hairs, which are seen right in the center. There's also very classical villus hairs, but when you notice there's loss of hair right in the specific areas, right in the center. There's also a bit of hair casting we see in the yellow form. Next. And again, this is the villus hairs I was saying. So this is actually the slide I was, I think I've mixed up the cases. So this is where now you see actually classical exclamation hairs, which is the arrow in blue. So this is where there's tapering of hair. There's a thicker hair, which is on the top, and then there's thinner hair as it goes to the root. Next. So again, a mild alopecia areata as a diagnosis. Next. Here we have a case of a 35-year-old Indian male with history of, again, history of hair loss since the last 2 months. No associated symptoms. Next. So it's very symmetrical, as you can see, but when you look at just in normal magnification, you can actually see that there are already some hairs back. On demoscopy, the reason why I specifically asked that, I mean, we posted this slide is this is a classical representation of exclamation hairs. There's also a little bit of villus hairs that we see right here, but you notice that there's a lot of empty spaces. So this is when you can actually notice demoscopy is actually very, or trichoscopy is very good in terms of diagnosing certain hair conditions. Next. So again, mild alopecia areata. Next. So again, what are we having as the diagnostic pearls? We have well circumscribed hair loss patches. They're often usually seen overnight, or it's more of a sudden, because the thing is that someone else tells them who it is, the hair is getting lost. They're not the ones who actually notice the hair themselves. It's usually smooth, normal skin in appearance, and there's hardly any pain or associated pruritus. In terms of trichoscopy, we see well demarcated patches, the classical exclamation mark hairs. Now, yellow dots and villus hairs is sometimes a bit more tricky to see in our African skin, but we definitely see more villus hairs. Empty follicles are seen in later stages of the alopecia, or I would say the plateau phase of the alopecia. Next. Next. So this is a 25-year-old patient, and we had recurrent episodic history of boils over the scalp, associated with severe itching, and has been there since the last 5 years. The most important is that this has been recurrent, has been treated multiple times in the past, but has not really had any improvement. They was using some antifungals, some antibacterials, has used quite a plethora of medication, but still hardly any improvement. The improvement, he says, is temporary for a while, at least when he's using medication, but as soon as he stops the medications, it comes back. Next. So here you see a very specific different type of alopecia. It's quite inflamed, and you can see a lot of hair crusting. There's a lot of red, angry tissue, which is staring at us. Okay, next. In terms of dermoscopy, the most important thing here we're seeing is what we call tufted hair pattern or hair follicles. It's a very specific and a very classical symptom for one specific type of hair loss. However, it is seen in other different types of hair loss as well in dermatology. But here, classically, we see a very specific perifollicular flaking. We see tufted patterns. We see a lot of scaling, and we see also a lot of perifollicular erythema or inflammation. Next. So diagnosis here was folliculitis decalvans. Next. So this is actually diagnostic cause of the folliculitis decalvans, not CCCA. So we see chronic cause with relapsing pustules, mild to severe crusting. In terms of history, they always are going to be talking about honey-colored crusting sometimes. There's always itching, a burning sensation, and patchy alopecia. And then we have classical tufted patterns on trichoscopy. There's a bit of honey-colored or red crusting, thick adherent white scales, perifollicular erythema, and loss of follicular openings that we see in trichoscopy. Next. So in conclusion, clinical history is vital in making a good diagnosis. Trichoscopy now gives a valuable addition to diagnostic acumen, especially in dermatological hair diseases. Cultural hair practices must not be overlooked. Early diagnosis and management is fundamental in getting good outcomes and preserving hair. To end, I want to give a shout out to my mentor, who has been an amazing teacher and a mentor. And he taught me one specific thing, which I'd like you to share today, though he's taught me many things. Success is not the key to happiness. Happiness is the key to success. If you love what you do in life, you will be successful and happy. Thank you, Prof. Over to you, Prof.
Thank you, Hashim. Let's move on with the histology and how to cope with it. Okay, I'd like to teach how we should manage the histological part when we have alopecias. I will go through some definitions, some diagnostic steps, a little bit of anatomy, physiology, histology, and I will show a couple of histology pictures about diseases that has been spoken. These are the abbreviation that you may find, and I will speak them out. What is alopecia? It's a condition with loss of hairs. It happened, and effluvium is a process of losing hair. It is happening. This is a very important slide that shows you the fourth zone of the hair follicle. So you have the infundibulum that goes from the surface until the entry of the sebaceous gland, and then from the sebaceous gland to the entry of the arrector pylori, you have the isthmus, and then the rest is the stem, and then you have the bulbus. The lower half, 50% is variable, and the upper half is the permanent tile, because every 7 years we renew our hairs. Sorry. In the ideal world, you could do 2 biopsies, one horizontal and one for the vertical cuts. And the best would be to select an inflammatory fresh zone of what you are seeing, or a positive pull test zone. Please don't make biopsies of ulcerations or of pustules, because this is full of other problems that you see, and this take away other criteria that you should use to make a good diagnosis. Important would be also to make a deep biopsy until the fat, so that you see the whole hairs. And even experts sometimes do sampling errors. So you have the head with a lot of zone, and you choose just one to make your biopsy, and this is not always the best. This happens. You make a lot of sections, you make PIS coloration, mucin stain, and elastica stain. These are important. What you can check mostly in the horizontal slides is the number of hairs. And in Caucasian, the normal number is about this one, and in African, the normal number is about this one. So you see there is a difference in normal number of hairs between skin types. Mostly you find anagen hairs, and then you can count a little bit, some few miniaturized hairs. You see few telogen or catagen hair, normal just maybe 2. And the terminal to vellus hairs is 2:1, and sometimes you also see better the polytrichia. In the vertical slide, so the classical slide where you remember, you see the whole histology, like for inflammatory disease and tumors, these are the vertical slides. So you see the whole follicle unit from the upper part to the lower part. You see where is the level of inflammation. You can see fibrosis. You can see as well polytrichia. You evaluate mucin, and you evaluate where is pus positive, if there is a positivity in the surface stratum corneum or in the one going into the hair follicle. And the phases of the hair cycle, anagen hair, so 85 to 100% of all hair on the scalp. And then you have the catagen phase, which is just 1% of the hairs. Is the brief transitional phase where there is apoptosis of the cells. And then it goes into the telogen phase between 0 and 15% of the scalp hairs. We lose about 100 hair per day. And let's see just one histological picture of the head, where you find classically the bulbus in the fat. The fat is like a protection of this bulb. And then you have the stem zone. And in other picture, you will see the other zone. And then the sebaceous gland, of course, you recognize. And you could see where is the level of inflammation. Here you see the bulb, you see the stem, the outer root sheath. There is a next picture that shows you exactly the fibrous root sheath, the outer clear pale root sheet, and then the inner root sheet more reddish, and then you see the cuticula, the cortex, and the medulla of the hair. And let's see in another cut the horizontal one, fibrous root sheet, outer root sheet, inner root sheet with Hensley and maxillary layers, the cuticula, cortex, and medulla. Here you see on the right part a fibrosis. You see this thick vertical change of the collagen fibers. In addition, you see some fibroblast into the fibrotic zone, like after a surgery or after an inflammatory process causing fibrosis of one hair follicle. And on the left side part, you see something vertical also. You see here, but it's not a fibrosis. This is a streamer or stele. And it's similar because you have a verticalization of the collagen fiber, like or similar as in fibrosis, but in addition, you see vessels, much more number of vessels. And this is something that you should be able to make the difference. Here is a horizontal cut through the stele, so a little bit of fibrosis, but then a lot of vessels, telogen hair, anagen hair with the hair inside, catagen hair with apoptotic keratinocytes in the epithelium. So there are not very good classification of hair disease. You could classify the hair diseases from the etiological point of view, but sometimes you don't know what is going on exactly from the inflammatory pattern, scarring, non-scarring, and so on. So there are not really official classification, but this non-official classification help us to understand what is going on. And I repeat something that I already said. There are like two halves of the hair follicle, and when you have a big inflammation in the upper half of the hair follicle, you may have a permanent alopecia because here you have the stem cells. And when you have an inflammation in the lower part of the hair follicle, this is the hair follicle that is renovating, so you have a reversible alopecia. This is one possible classification of primary cicatricial alopecia, so more lymphocytic, more neutrophilic, and mixed. And what I can tell you is that in 12.5% of cases, there is more than one case of alopecia. Mostly you have androgenetic alopecia and central centrifugal alopecia, or central centrifugal alopecia and traction alopecia, or androgenetic alopecia and traction alopecia. This has been published a couple of years ago. And here is another simplified way to see the alopecias. So you have the lichen planopilaris with a kind of variant or a similar pattern, histological, I mean, of the patterned frontal fibrosing alopecia. The next one with a similar inflammation, so a lichenoid interface dermatitis, chronic cutaneous lupus erythematosus. And then you have central centrifugal alopecia that has similarities to folliculitis decalvans. And then you have acne folliculitis, acne or folliculitis chenoidalis nucleus, and dissecting folliculitis as the scalp with major disruption of the skin and large alopecias. And then you have not classifiable alopecias. A couple of words about alopecia androgenetica. There are a lot of patients. There is the male pattern androgenetic alopecia and the female pattern androgenetic alopecia. From the histological point of view, in horizontal section, you see the quantitative and the size of the hairs. So there is a normal number of hair follicles. This is very important. You see normal sebaceous gland. What you see is mostly that there is an increased number of vellus hairs or of miniaturized hairs with larger sebaceous gland because the hair shaft is smaller, so they look like larger. You see here, look, the larger hair follicles are the normal one, and the small one where you see as if the sebaceous gland would be bigger, but they are not, around smaller hair follicles. So miniaturized or vellus hair, normal hairs. The most hair here are anagen hairs. Let's go in another picture. Miniaturized hair, normal size hair, telogen hair, and the other are anagen hair. Here you see like a sleeping hair. It's the hair bulb came up in the upper dermis, and usually in the lower part here you see a stele, a streamer that you don't see well here. miniaturized hair, normal hair, miniaturized hair, looking larger, sebaceous gland, but not being larger. So this was alopecia androgenetica. A couple of words about alopecia areata. This is more rare, of course, and you have several clinical patterns. We don't discuss this too much. The clinical characteristic has been good discussed by Hashim. Let's go to the early histological changes. So again, you have normal number of hairs, but an increased number of catagen or telogen hairs. So similar like alopecia androgenetica, increased number of miniaturized hair, similar to alopecia areata, androgenetica. However, you have something in addition. You have a peribulbar inflammation, which is classical and a good diagnostic point, sometimes with some eosinophils around the bulb. You may see pigmented hair casts that you also see in traction alopecia. So you see there are different histological changes, some shared with alopecia androgenetica, some other shared with traction alopecia, but something I cannot say specific, but different from these other alopecias is the peribulbar inflammation, maybe with some eosinophils. And later you see that the majority of hair are catagen or telogen. You see numerous miniaturized hair, and the peribulbar inflammation still remain. And here you see the peribulbar inflammation, and as well you see it here, and look, the red cells that you recognize here. So these are all eosinophils. So peribulbar inflammation with eosinophils. Let's go to something easy to recognize, lichen planopilaris. The clinical picture has been, again, well discussed. What you see histologically, you see a band-like lichenoid interface dermatitis of the infundibulus, of the isthmus, sometime also of the epidermis between two hair follicles, sometime. You may see, but mostly it's only on the follicle. You may see a thick epidermis, you may see a larger stratum granulosum, and then you see a band-like loss of elastic fiber. Of course, you have to stain for the elastic fibers, and you see this band-like along the hair follicle, and sometimes you see it also under the epidermis. You may have loss of sebaceous glands. You usually don't have very deep inflammation. You don't have a lot of interfollicular inflammation, so between the hair follicle, no inflammation, and you don't have mucin deposits. And this is helpful to make the difference between this entity and lupus erythematosus, the chronic lupus erythematosus. Let's see here. You see the fibrosis vertical. Here you see the perifollicular inflammation, and when you again inflammation, and these are anagen hairs. You see around the bulb there is no inflammation. No inflammation is everything superficial. And here you see that there is an interface change with ballooning of the basal cell of the epithelium of the hair follicle. The same you see it here. And you see sometime polytrichia, so more than one hair coming out of one follicle, two, sometimes you see three, like here. And look, onion-like fibrosis around the hair follicle, which is classical, the inflammation. And here you see very nicely that there are apoptotic keratinocytes along the basal membrane zone of the hair follicle in this infundibulum. And you see fibrosis on the left side, but you don't see changes on the epithelium. Here you see as well changes, basal degeneration of the epithelium. And look, disappearance of the elastic fiber, band-like. Here is normal elastic fibers. Here you see a vertical fibrotic zone, another vertical fibrotic zone. What is the possible histological differentiation between lichen planopilaris and the fibrosing frontal patterned alopecia? So they have a very similar band-like scar with a couple of differences. The patterned fibrosing alopecia has a little bit more ondulated base of this band-like loss of the elastic fibers. And the line in lichen planopilaris is more horizontal, but this is very, very much fine-tuning only for experts. And then the scar in the peripheral, the patterned fibrosing alopecia, it's less than 1 millimeter deep. In lichen planus is deeper, and you may have some remnants of elastic fiber in the patterned fibrosing alopecia, despite, and in lichen planopilaris, they are wiped out. Let's see it as an example. Look, complete loss of elastic fiber, horizontal line, lichen planopilarus, no remnants of elastic fibers in the fibrotic zone, like planopilaris. In the patterned fibrotic alopecia, you see the fibrotic zone is a little bit more wavy. It's not a straight line like here. And you see some remnants of elastic fiber that you see here. Lupus erythematosus, we are narrowing the end. Only in 10% of the cases is associated with systemic lupus. There are more women. Let's go to the histological change. So similar of like lichen planus, you have a lichenoid inflammation of the epidermis sometime, and sometime just of the follicle. What you see here is a thinned instead of a thickened stratum granulosum. You have, in addition to the follicular inflammation with lichenoid changes, you have interfollicular perivascular inflammation, you have mucin changes, and the loss of elastic fibers is more patchy. These are the difference between this entity and the lichen planopilaris. Maybe you can do CD123 immunohistochemical coloration, and you would see a little bit of augmentation of cells and some in clusters grouped. Here you see that there is a perifollicular, but also a perivascular, superficial and deep inflammation. Look, the white discoloration here is mucin. You see the interface changes with apoptotic keratinocytes, also in the interfollicular epidermis, but this is not specific, may be seen also in lichen planopilaris. Look at the mucin. Look at the mucin here without the Alcian blue stain or iron colloidal staining, and here you see where it is when it is stained, some CD120T positive cells, and the PIS coloration is showing sometime, rarely I have to say, but sometime a thickened basal membrane zone. In general now, when you have scarring alopecias, let's speak about the central centrifugal alopecia or acne keloidalis, folliculitis keloidalis. They are similar, and in red you see what you find more in acne or folliculitis keloidalis, and in black what you see in both entities. So there is more inflammation, more plasmocytic inflammation, and more deep inflammation in the acne or folliculitis keloidalis, and a little bit less inflammation in the central centrifugal alopecia, but still with a lot of scarring. And in dissecting folliculitis, you see a lot of neutrophils. You see like lakes of neutrophils, and this is not specific, but very classical of this kind of inflammation with deep inflammation, abscesses, and several plasma cells. Here is an end stage of alopecia canceling a lot of hairs. You see just fibrosis, only few remaining hairs, and then everything went. Here you see just no hairs, so this is not specific. And here you see scarring alopecia with polytrichia, like here 3 hair coming out of the follicle, some perifollicular inflammation, which is not specific, maybe some plasma cells. You don't see the interface changes. This could be central centrifugal alopecia or folliculitis decalvans. When you see some neutrophils, it could be like in folliculitis decalvans, and when they are more superficial, and when you see lake of neutrophils and superficial and deep, then you have dissecting folliculitis of the scalp. Here you see polytrichia, you see even granulomatous changes, plasma cells, all of them are plasma cells, a lot of lymphocytes, one remaining follicle but destroyed. You see here a lot of plasma cells and granuloma formation, which is something that you may see in different alopecia when there is the destruction of the root of the hairs and a lot of fibrosis. Here are some references from the literature and one very interesting book where you find all histological changes. Thank you for listening. Me and Hashim are here for some questions if you have some.
Thank you so much to both our speakers, Prof. Helmut and Dr. Hashim. We really appreciate your time and your expertise. Now for the Q&A section, we have a few questions in the Q&A box. The first one is, I think it's for Prof. Helmut. How can ethnicity affect the interpretation of scalp biopsies?
I've not heard acoustically. Sorry, can you repeat?
How can ethnicity affect the interpretation of scalp biopsies?
I don't understand the how. So it's a fact that you have more hairs in Caucasian skin in comparison to the, let's say, pigmented African skin. And this is a fact that you should know. And so when you see less hairs, and you know the patient is from African origin, you should not expect the number of hairs that you expect in a Caucasian skin. Maybe I answered the question, I'm not sure. Hashim, did you interpret similarly like I did?
Yes, I think that's, I think from that, yeah.
Okay. The next question is, what challenges do you face differentiating early androgenetic alopecia from telogen effluvium? And then there's a second part. What strategies have you employed to differentiate them histologically?
I can give an histological answer, but I would say the answer is clinical. I mean, a telogen effluvium is something different than androgenetic alopecia from the pattern point of view, from the dynamic point of view. Both may show, let's say, a normal number of hairs, and then you see miniaturized hairs, but the clinical happening is different. The history of the patient is different.
I agree.
The next attendee says, sorry, I joined late and might have missed this part, but do you often encounter mixed pattern alopecia in practice? How does this influence biopsy site selection and interpretation?
I let Hashim answer first, and then maybe I add something if necessary.
So that's the major point of this particular presentation, because when you look at hair presentations, most of them have mixed patterns. You see, there's sometimes tractional alopecia mixed with frontal fibrosing, or androgenetic with like telogen effluvium. So many different patterns that occur, and hence not just the clinical acumen that we need to train young residents on, but using new tools like, for example, the dermoscopy, finding out which parts to do the proper biopsy from is very important, because when you have so much of scarring, so much of hair loss, and you do an improper biopsy, an improper result or histological report will follow. So you will not be able to manage a patient accordingly. Hence, that's the most important in terms of using these particular tools and clinically diagnosing, but using histological to confirm. Yes.
I have to say, thanks to the very good increasing knowledge is using the dermoscope, we can avoid to make some biopsies. Sometimes it's still necessary, and then you do it. And maybe for the advice is to choose the most inflammatory peripheral lesion where you see some inflammation, not a zone of ulceration, not a zone with a lot of pustules or a lake of pustule, not there. So where it's most inflammatory with not other secondary changes, because there you will find the best tissue to evaluate what pattern is going on, what inflammatory pattern is going on.
Okay, thank you. The next one looks like it's for both of you. What next steps do you take when the clinical suspicion and histological findings are discordant?
Hashim, maybe you begin and then I continue.
So you see, that's the reason why it's so important to know where the biopsy is taken from, because the inflammation, where you've taken it from, the clinical history based diagnostic approach is then improved with where you do the biopsy from. So especially when you have a very specific presentation, right? That's when you know that at least you know that kind of a thing. But it's a mixed picture, right? Of course, when you're expecting something which is mixed. But let's say, for example, if you're looking at diagnosis of, let's say, for example, frontal fibrosing alopecia, all right? But the diagnosis or the histology has come back as alopecia areata, then you know that's completely discordant. It's not matching, that kind of thing. So then you have to maybe repeat a biopsy perhaps, because in our setting, histology is a bit more challenging. We have very few dermatopathologists here. Most of the times, the normal histologist is the one who usually does the readings. So sometimes it can be that particular kind of a scenario. I think over to you, Prof.
Okay. I think one important, thank you. I agree to all points. I add a couple of few additional points. One is that you know exactly where you are sending your histologies. So the best would be to choose a laboratory where you know that somebody reading slides of alopecias or with experience reading alopecias works there. See, this is very important to have the highest know-how about this topic. This is one. Having saying this, the next point is take the phone and discuss the clinical pathological correlation with the pathologies in the dermatopathology. So you explain what you see clinically, maybe you can share a couple of clinical images, and then the other person should interpret the biopsy or what he sees or she sees in the microscope, and integrate this information. And at the end, speaking together, you move forward. And the last point would be to make a rebiopsy if there is no agreement, if there is something that really does not fit and you are not helped, you cannot help your patient.
Okay, thank you. So the last question, what role do tools like trichoscopy add in your experience?
So when you look at trichoscopy or dermoscopy, this is tools which are now looking at increased clinical acumen, increased diagnostic capacities, and reduced need for histologies if not necessary. So this is something which every dermatologist should start doing in their clinics, if not at least already. It really helps also to show patients what is going on, because there are now video dermatoscopes, there are video trichoscopes. So when patients understand the level of, for example, follicular osteodegradation they have, then their expectations are also met, because when they see that, I mean, this is something which is a bit improbable for them to get the hair back, then they understand that there is no possibility of maybe trying minoxidil or any other medications, because you see, hair is a very important aspect of a personal appearance. Patients are going to do a lot of things. For example, like my patient who did the hair transplant, they are going to do many things, expensive medications, to try to get the hair back. It's our job as dermatologists to make sure that they are on the right track, given the right medication for the right diagnosis.
Okay, thank you very much to both our speakers for sharing your knowledge, your expertise with us. We really appreciate it all. And now, just to close up the webinar, we'd like to thank you also to our attendees for joining us for this webinar, and follow us on our social media pages to learn about upcoming events. Our next webinar will be on the 16th of July at 2 p.m. UTC, where we'll be discussing vascular anomalies, infantile hemangioma. Our speakers are Dr. Anna Maria and Dr. Doreen Mapunda. So also follow us on our other social media pages as outlined here. And thank you also to our supporters, Sarah B and the Ellis Foundation. See you next time.